Okay, good morning. I am Dr. Rajita, professor in Department of Pharmacology. Now I am going to speak about the pharmacotherapy of glaucoma. Actually, the glaucoma may be the small topic, but it is very important when it comes to the need. Not only the pharmacology, the questions may come from the ophthalmology too. So there also will covered about mainly the pharmacotherapy of glaucoma. So with this small topic, you can attempt 2 to 3 questions by knowledge of this particular topic. So let's come to the pharmacotherapy of glaucoma. Actually, what is glaucoma? The glaucoma is a group of disorders which ultimately working on optic neuropathy, the damage to the progressive damage to the optic nerve, which leads to the visual field defects. It may be there will be invariability of the increased intraocular pressure. That is the main reason for this particular glaucoma. So, what is intraocular pressure and what made that particular intraocular pressure to be raised? As we know, there is an aqueous humor in the eye which has to be produced for and which has to be moved from the posterior to the anterior part of the eye. So here, which I wanted to, okay. So here from the particular ciliary body, this is the ciliary body. From the ciliary body, sorry. Sorry for the interruption. Yeah. Is that slide are visible, sir, for you?
No, doctor. Slide suddenly.
Okay. Then
Yes, visible now.
okay. So from the posterior chamber to the anterior chamber, the aqueous humor has to move. This slide explains about this particular aqueous humor which is produced by this ciliary body, ciliary muscle from the ciliary body, and from the posterior chamber, the arrow marks is showing that from the posterior chamber, that is posterior chamber is behind the iris. Here the yellow color, the mark is showing that iris, and from the posterior chamber, the humor, aqueous humor is moving towards the anterior, and from here, these are the dots. So some poles are showing this. This is through the trabecular meshwork, that is trabecular outflow. And below it, there is upioscleral outflow is also there. So these are the two routes which are making the drainage of the aqueous humor. One is trabecular outflow and number two is upioscleral outflow. Trabecular outflow is more than 80% and upioscleral outflow is 10 to 20%. So from where we are getting this particular aqueous humor? As I told you, from the ciliary body, from the ciliary epithelium. So when it comes to the treatment, we should know who are the people, who are the receptor, what are the systems which are involving the production of this particular aqueous humor, so that we will know what are the on which we have to act so that this particular drainage of the aqueous humor can be enhanced or production of the aqueous humor can be enhanced. So what we are knowing, because and intraocular pressure is increased because of the two reasons which making that particular glaucoma to be developed in an individual. So what we have to do? We have to decrease the drainage, increase the drainage so that the intraocular pressure will be decreased, or we can decrease the aqueous humor. So what are the receptors or what are the systems which are involved in the production of the aqueous humor? Here, alpha 1 and alpha 2 receptors, beta 2 receptor and carbonic anhydrase receptors are mainly present over this particular ciliary body. So I just wanted to tell what are the different types of the glaucoma. Mainly, there are two types, primaries and the secondary. When it comes to the primary, congenital glaucoma, in the primary, they are again based on the angle. Based on the angle, they are again divided into types. Primary angle, open angle glaucoma. Number one is the primary open angle glaucoma. The angle is opened. That is open angle glaucoma. Second is primary angle closure glaucoma. What is the angle here? This is iridocorneal angle. This is the angle. The red color is showing that is an iris, and the above that gray color is the cornea. So iridocorneal angle, if it is closed, the place where the trabecular outflow is placed actually, and then near to that there will be uveal scleral outflow. So when this particular angle is closed, the trabecular outflow will be diminished, and also uveoscleral outflow also will be diminished. That makes the increased intraocular pressure. When it comes to the open angle glaucoma, the angle is normal only, but because of the abnormalities of the production and abnormalities of the drainage, we are getting the glaucoma. So we have to treat the different types of the glaucoma. One, open angle glaucoma, another one is the closed angle glaucoma. Majorly the closed angle glaucoma, there will be only little role of the pharmacotherapy, that to prevent the complications. But when it comes to the open angle glaucoma, the major role of the treatment is pharmacotherapy. So the angle, iridocorneal angle is intact, but because of the overproduction of the aqueous humor or under drainage of the aqueous humor leading to the glaucoma. So what we have to do, what are the chief measures, therapeutic measure to lower this particular intraocular tension? One is by reducing the secretion of the aqueous humor. Another one is by promoting its drainage. So ultimately lowering the IOT retards the progression of the intraocular tension. So what are the drugs? Beta adrenergic blockers and beta adrenergic, alpha adrenergic agonists, prostaglandin analogs, carbonic anhydrase inhibitors, and myotics. Actually, the questions may come in a need that they may ask about the examples of these drugs. They may give you that beta adrenergic block. They may not ask you like a beta adrenergic blockers, but what are the drugs can be used for the treatment of the glaucoma, and they may give the options as a beta adrenergic agonist and antagonist and something else. So we should know here the beta adrenergic blockers, which will end with the lol, timolol, bitoxolol, libugulol, and cartinolol. They are ending with the lol. So these are the drugs which are used. And alpha adrenergic agonist. In the alpha adrenergic agonist, there are alpha 1 and alpha 2. Both agonists can be used for the glaucoma. Here the dipivefrin. Dipivefrin is the drug which is adrenaline prodrug. Actually, adrenaline cannot cross the cranial membrane. That's why we are using the dipivefrin so that it can cross and can produce some effects. And apraclonidin and brimonidin, they are ending with the dins. So these are the alpha agonists and prostaglandin analogs. Prostaglandin analogs are ending with the prost. Prostaglandin analogs are ending with the prost. That is latanoprost, travoprost, and pimatoprost. So these prostaglandin analogs, they are supportive towards the action of the prostaglandin. Carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. They are ending with the mides. That is dorzolamide and brinzolamides. Next, myotics. Pilocarpine, physostigmine, and ipothiopate. These are the drugs. Myotics, as you know, they are decreases the size of the pupil. That is called the myotics. So these are the drugs. Beta-adrenergic blockers, alpha-adrenergic agonists, prostaglandin analogs, carbonic anhydrase inhibitors, and myotics. Let's come to the mechanism of action of these individual drugs. First, let's come to the meiotic action. Meiosis, I already told you, when they are decreasing size of the pupil, that is called the meiosis. These meiotics mainly cholinergic agonists means actually iris will contain the two types of the muscle fiber. One is circular muscle fiber, which will be in a round, radial muscle fiber, which will be the longitudinal to the circular muscle fiber. So when the contraction of the sphincter pupillae, which is nothing but the circular muscle fiber contraction. So I'll show you with the diagram here. Here what happening because of the dilatation of the pupil, there will be angle closure or closed angle will be morely closed. Here because of the dilatation narrow of the iridoangle cycle, angle, iris makes contact with the lids, blocking the passage of the aqueous humor from the posterior to the anterior chamber. So there will be pressure will be built and further aqueous humor outflow will be decreased. So when we are giving the meiotics, see the image C showing the meiosis. Meiotic drugs has been given and when the pupil size is decreased, there will be opening for the angle so that there will be drainage is happening. From the posterior to the anterior drainage, there is a space because of the meiotics. Even if this is angle closure glaucoma, in the type of angle closure glaucoma, the action of the meiotics are like this. When it comes to the open angle glaucoma, there is also in the open angle glaucoma, a meiotics role will be there. How they are acting in the open angle glaucoma. In the site of action, meiotics contracts the ciliary muscle. This pink color is the ciliary muscle. When it is contracting, it is because it is contracting, it is improve the trabecular patency. So the trabecular outflow will be improved by this meiotic. So meiotics has a role in open angle and as well as closed angle glaucoma. And next come to the other group of the drug. Beta blockers, alpha agonists, and alpha 1 and alpha 2 agonists and carbonic anhydrase inhibitors. These four groups, beta blockers, alpha 1 agonists and alpha 2 agonists and carbonic anhydrase inhibitors. All these four groups, what they are doing? They are reducing the aqueous humor production by the ciliary body. Already I have told you that these are the receptors which are present in the epithelium of the ciliary body. So what they are doing? Alpha receptors, they are on the pupial arteries, vessels. So what, because of the contraction of the vessels, there is no blood supply to the body, ciliary body. So there is no production of the aqueous humor. Carbonic anhydrase is an enzyme which because of this particular enzyme, there is a production of the aqueous humor. When this particular enzyme is inhibited, that is H2O and CO2 by leads to the carbonic acid, that production is inhibited. So that aqueous humor production will be inhibited. And beta 2, beta blockers, actually beta agonists are increasing the production, beta blockers are decreasing the production. Beta agonists are increasing the production and increasing the drainage. Beta blockers decreasing the production. When it comes to the prostaglandin analogs, prostaglandins are nothing but the inflammatory mediators. These are the inflammatory mediators which have a role on the gastric juice production and also aqueous humor production. So we are using the prostaglandin analog. And adrenaline, because of the beta 2 action, it is increasing the drainage of the aqueous humor. So let's think. Actually, we know that normally myotics has a good role in the prostaglandin, this particular open angle and as well as the closed angle glaucoma. But we have a more advantages with the beta blocker when it comes compared to the myotics. Because of the contraction of the ciliary muscle and because of this contraction of the circular muscle fibers, they are active. But because of those contraction, we are getting some kinds of the side effects and some kind of the problem with these drugs. There will be with the beta blockers, those adverse effects or those problems can be prevented. Like there will be, with the beta blocker, there will be no change in the pupil size and there will be no diminution of the vision when it comes to the dim light and no inducing the myopia in the young individual. So, and there is no headache because of the contraction. There will be headache, brow headache and the headache, frontal headache because of the iris and ciliary spasm. So they can be prevented by using this particular beta blocker. So let's come to the pharmacotherapy. How we have to give these particular drugs. First, you have to start with the monotherapy with prostaglandin analogs or topical beta blockers. Prostaglandin analogs are very effective and I'll tell you why. And next, when it comes to that particular, if it is IOT is not attained to the desired levels, then change over to the alternative. Either first start with the prostaglandin analogs, next you can start with the beta blockers, and next you can go with the alpha 2 agonist like bremonidine, dorzolamide, and next you can go with the topical myotics and acetazolamide, which is nothing but the carbonic anhydrase inhibitors. Let's come to the individual drug systemic and as well as ocular side effects of these particular drugs. Cholinergic agonists, which are nothing but the myotics, we are already know, I have already discussed that because of the contraction of the ciliary muscle and also circular muscle fibers in the iris, there will be headache and the brow pain and due to the persistent spasms and retinal detachment. Because of this persistence, there will be chances of retinal detachment by these particular drugs. Systemic adverse effects are rare, but ocular itself a little bit cumbersome and not acceptable adverse effects. When it comes to the beta blockers, stinging redness, dryness of the eye and high corneal hyposthesias are the ocular side effects. But when these particular topically administered drugs through the nasolacrimal duct absorption into the systemic circulation, the drugs which we have given may be topically, but through the lacrimal duct, these drugs can be absorbed into the systemic circulation. Because of the absorption into the systemic circulation, there will be some kind of the problem like life-threatening bronchospasm. Yes, this is the life-threatening bronchospasm in the patients of an asthma or COPD. Because it is absorbed into the systemic circulation, there is life-threatening bronchospasm in the asthmatic patients and COPD, chronic obstructive pulmonary diseases conditions are having patients, and also these beta blockers also reduces the heart rate. So the patients having the bradycardia and this also the patient it is also accentuates heart block and congestive heart failure. So we should be very cautious to prescribe these particular beta blockers with the patients who are already having the asthma, congestive heart failure, heart block, or bradycardia or arrhythmias, and COPD patients. When it comes to the prostaglandins, there is little bit ocular irritation and blurring of the vision and increased iris and pigmentation, thickening and darkening of the eyelashes and macular edema. See, I already told you, prostaglandins are the inflammatory mediators. So, because of these inflammatory mediators, because of the inflammation, actually, there is an edema, there is a thickening, and there is hyperpigmentation. And there are no systemic side effects at all. When it comes to the alpha 1, alpha 2, there are itching, lid dermatitis, follicular conjunctivitis, and they are also causing the mydriasis and eyelid retraction, dryness of the mouth. So, and when it comes to the systemic, all the sympathetic adverse effects can be considered to when we are prescribing these drugs, because they can be through the nasolacrimal drug, they may be administered, they may be absorbed into the systemic circulation, so they may cause the hypertension, all those things, vasoconstriction, all those things can be happened. Next, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitor is a diuretic actually. And what it is doing, it is inhibiting the enzyme. So what they are doing, there is a burning and ocular stinging and edema, and there are again systemic paresthesias, hypokalemia, acidosis, malacia, and that depression. These are the adverse effects of the individual drugs. So what we are doing, we have to give a treatment. This is the treatment for the mainly open angle glaucoma. When the patient with the open angle glaucoma, you have to first start with the prostaglandin analogs or beta blockers. Next, if not responding, when you started with the prostaglandin analogs, switch over to beta blockers. If there are no contraindication to the patient who use the beta blockers, next, if I add the beta alpha 2 agonist and next topical myotics and acetazolamide, carbonic anhydrase inhibitors, intravenous or topical or oral, all are available. Let's come to the acute ankle closure glaucoma. This is an emergency condition actually. If we left the patient like that, the patient will lands into severe optic neuropathy and lands into blindness. This is the third leading cause of the blindness in the world. So we should alerted immediately when the person came with the watering of red eye and the pain. So we should be alerted to know, is it because of the glaucoma, and that has to be immediately treated to relieve that particular condition symptoms, so that progressing of the optic nerve damage will be diminished. Later we can go with the surgical intervention. What are the pharmacotherapeutical interventions we can do? First, you have to start the mannitol and intravenously. Actually, when it comes to this particular, normally when I have told you in the previous slides, you might have thinking that by using the myotics, because it is reducing the pupil size, it can be useful. Actually, to work a myotics, because of this increased intraocular pressure, the myotics cannot work. So first what we have to do is we have to decrease that intraocular pressure by giving the systemic diuretics, that is mannitol. Next, topical or oral diuretics. Topical acetazolamide, which is nothing but the carbonic anhydrase inhibitors, and followed by intravenous acetazolamide, followed by oral acetazolamide, that is carbonic anhydrase inhibitors. Next, give the myotics. Until then, we cannot, even we are giving the myotics, we cannot see any response. So first mannitol intravenously, next carbonic anhydrase, because they are low ceiling diuretics. So systemic first high ceiling, next first systemic mannitol, next acetazolamide IV, followed by oral, next in the miotics. There are so many surgical procedures for the this particular angle closure glaucoma, that is trabeculoplasty, iridotomy, iridectomy, filtering procedures like canaloplasty, gonioplasty, cyclodialysis, and celerotomy. These are the surgical intervention for the angle closure glaucoma. So let's come to the MCQs. I have already told you there are two types of the mainly glaucomas, that is congenital and secondary. And there are, when it comes to the primary angle closure glaucoma and open angle glaucoma. Most of the pharmacotherapy we are giving for the open angle glaucoma. When it comes to the angle closure glaucoma, to prevent the complications, we will initially treat with the pharmacotherapy and next surgical intervention will be done. Okay, let's come to the MCQs. A 55-year-old man was brought at night to the hospital emergency with severe breathlessness and wheezing. Chest auscultation revealed marked bronchoconstriction. He was managed with the 100% oxygen and nebulization with salbutamol and ipratropium bromide. Okay, the asthmatic attack was controlled. History taking revealed that he was having mild episode of asthma on and off, but never had such a severe attack. Yesterday night, he used ophthalmologist prescribed eye drops for visual difficulty and frontal headache. The intraocular pressure was measured to be 24 and 25 millimeter mercury in right and left eye. What could be the drug in eye drops? So what could be the drug in the eye drops? So here the intraocular pressure is 24 and 25. Actually normal intraocular pressure here is 17 to 21 millimeter mercury. So here the mercury is increased. So 24 to 25 means the person is having the glaucoma. That is the one diagnosis. And when it comes to this particular 100 person with the asthmatic attack, so the person has an asthma, is a known patient of asthmatic patient, and he has taken a drops for glaucoma, some eye drops for glaucoma, and the asthmatic effect, there will be exacerbation of the asthmatic attack. That is what we can say, bronchoconstriction and that. So let's come to the answer. That is timolol. Lol means beta blockers, which I already told you. There will be systemic adverse effects. Major limitations in the use of ocular beta blockers. So first drug of choice, I told you, prostaglandin analogs, which are decreasing the uveoscleral outflow and also trabecular outflow. Beta blockers are also very good choice when compared to the miotics, but systemic absorption leads to the side effects like life-threatening bronchospasm in the asthmatic and COPD patients. So here the patient was known asthmatic. So because of using of these drugs, exacerbated the asthmatic attack. That is what the answer. The answer is C, timolol. Okay, next go to the MCQ 2. A 30 years old lady came to the ophthalmology OP with the complaints of redness in eye and frontal headache. Her IOD is 32 to 36 millimeter mercury. What is the order of management in this condition? So So what is here clearly showing with the symptoms? Redness eye. Red eye is an emergency condition in the department of ophthalmology. So we should be immediately alerted with that particular condition. And here the IOT is 32 to 36. 32 in the right and 32 in the left. So normally 70 to 21. There are very high intraocular pressure. So redness of eye and frontal headache. Red eye is nothing but we should be cautious, and increased intraocular pressure, that is showing that diagnosis of acute closed angle glaucoma. So what is the order of treatment for the closed angle glaucoma? What we have to choose first, which kind of the drugs we have to give for this particular patient? Is it pilocarpine, acetaldehyde, mannitol, or mannitol, acetaldehyde, pilocarpine, or acetaldehyde, mannitol, pilocarpine, mannitol, pilocarpine, acetaldehyde? Think. The answer is first, mannitol intravenously. The answer is B. Wherever the mannitol is first, actually the mannitol is first in the B and D. After the mannitol, intravenous mannitol, we have to give intravenous another diuretic. Not immediately after mannitol, we cannot give the pilocarpine. After the mannitol, we have to give intravenous acetazolamide too. So, when IOT is very high, the iris muscle fails to respond to the myotics. So, we have to reduce the tension before giving to the myotics. So, angle closure glaucoma, hypertonic mannitol 20% or glycerol 10%, and next acetazolamide IV followed by oral acetazolamide. Next, give the myotics, that is nothing but the pilocarpine. After that, we can give topical beta blockers if there is no contraindications. Next, you can go with the apraclonidine or latanoprost. Here, we are not using the latanoprost drug of choice here. First, angle closure glaucoma, latanoprost is not a first drug of choice. IV mannitol is the first drug which has to be given. So, drugs used to be terminated. Later, surgical intervention can be done. Let's come to the MCQs.
Doctor, just a minute. It's only 1 minute left. So can you quickly do this?
Yeah, yes. So, 30 years male patient who was diagnosed with the macular edema with a glaucoma. Which drug should be avoided? The drug which has to be avoided is, what is the drug? The person is having the macular edema. The options are latanoprost, timolol, and apraclonidine. So, ocular side effects of the prostaglandins is, one of the severe ocular side effects is macular edema. So, prostaglandins analog should not be the first choice. So that there will be no maculopathy. That is the, okay, with this we have finished. Here the retinal detachment, we can see the retinal detachment, which group of drug is the adverse effects? The myotics. Adverse effects is the retinal detachment. This is an Oxysert. So it is the newer drug delivery system, so that it can continuously release the drug by keeping the drug into the eye. Full days are. Okay, this is what about the glaucoma. Thank you.